Hello, everyone. Thank you for joining us for today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I'll be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. It's in the lower right-hand corner of your screen. You should see a chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLink Medical. We provide evidence-based, CME accredited education in wellness medicine. If you're looking to transition your practice, already in transition, fully transitioned but looking for more ideas and resources, if you desire a small practice doing bioidentical hormone replacement only, or a medium-sized wellness practice, or a large multi-specialty integrated practice, don't miss the debut of the Business of Creating Health, which will provide the knowledge to make an informed decision for the model that best suits your specific needs. Meet with like-minded colleagues and our faculty team of experts and create an actionable plan to move you in the direction you want to go. Then we'll look to develop the inspiration to help your patients get healthy, stay well, and feel great about themselves. You in turn will create a satisfying practice that create lasting relationships for you and your patients. This is truly a unique opportunity for a one-of-a-kind course. Don't miss out. Super early bird rates expires on Friday. Please go to the WorldLink website for details. We'd like to take a moment and say a special thank you to MedQuest Pharmacy, who provides us with the educational grant for today's webinar. We are grateful for their continued support and recognize the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are truly leaders in the industry, and we're proud to be supported by them. Dr. Neal Rouzier is a pioneer and recognized leader in the bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He's lectured worldwide on the benefits of hormone replacement therapy. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It is my privilege to welcome Dr. Neal Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neal.
Hi, Mary. Thank you. Good morning, everyone. It's still morning here in bright, sunny Palm Springs. I think we're supposed to have a high of somewhere around 85 today. For those of you that have not been to my favorite place on earth, it's Yosemite Park, which is going to be a banter year because of all of our snowfall that we've had. The waterfalls will be in full bloom. My second favorite place that I'll be going to is also full of water, and that's Glacier Park in Montana. It's a great year to go to those places because of all the rainfall that we've had here in the West after 5 or 6 years of drought. Anyway, this is part 3 of the webinar series. This is first to introduce this topic. It's going to be a report recently about testosterone being linked to serious blood clots, with the key emphasis on the word may. And I should start here to educate you like I do for everyone else that always sends me emails and says, you know, what's your opinion of this paper? What's your opinion of this article? And I send an email back and I say, did you read it? And I said, well, yeah. I said, well, what did the article say? Well, they said there's some blood clots. I said, no, did you read the article? What did the article say? Did it say that there's a significant increase in blood clots? Well, yeah, that's what the title says. No. Did you read the article? Everyone says, well, no, I didn't really read the article. All I read was the title. Well, if you ask me my opinion of something, I will turn around and say, did you read the whole entire article? Because if you read the article, you'll find in the article itself the rebuttal to the article itself. So anyway, this article starts off by saying testosterone treatment can increase a man's risk of potentially fatal blood clots. Key emphasis on the word can, key emphasis on the word may. May also means may not. Can also means cannot. The risk peaks rapidly in the first 6 months in this study that was done in Europe. It lasts for about 9 months and then fades gradually thereafter. And after a year, there's actually a decreased incidence of blood clots just in that first year. There's a 63% increased risk of blood clots. Wow! That means 63% of people are going to get blood clots. No, that's a relative risk. That means out of 2 patients, 1 patient got a blood clot and 1 patient did not get a blood clot. There's your 63%. That doesn't mean that 10,000 out of 10,000 people that you're going to have 6,500 people with blood clots. So again, there's a big difference between relative and absolute. The absolute risk is very low. This is in response to the FDA in June requiring that all testosterone products carry a warning about DBTs. The FDA's responsibility is not to teach us or show us how to practice medicine. It is an agency that approves medicine use for the public. It approves efficacy, it approves safety. There's no study, other than this one here, which is, again, a lousy observation. There's no randomized controlled trials that show risk or harm, and we'll review all of those. However, there's one doctor that reported it to the FDA that in his evaluation there was an increased risk of strokes, heart attacks, as well as DVTs and PEs. It's the FDA's responsibility to advise the public of that. That's the responsibility. If the FDA did not do it, then they're going to be liable. So to cover their butt, anytime a side effect is reported to the FDA, they will report it as a potential side effect. And of course, since blood clots could be fatal, it's now a black box warning. There could be a risk of blood clots, although we do not see that in any randomized controlled trial, and that's what we're going to review. But you can see how the public will get all upset because it can and it may, and can and may means that it could also not. This study did not establish a direct cause and effect relationship, however. Read the study. Well, it could, but it didn't really establish whether or not there was really a cause and effect. There was not a control group. It was not blinded. It was, okay, well, these people took testosterone, maybe they didn't, but there's an increased risk in those that we think maybe did. So it's a neat observation. What you take with that observation is trash it and then do a randomized controlled trial to see if truly what you observed is actually true. Nor does it mean there's a significant risk of DVT for the average guy. The risk is low to begin with. Yeah, okay, now we see the true risk. It's extremely low. The overall risk is 1 additional blood clot per 1,000 men in that study, in that observation. Well, sorry, but that's not a statistical significant result. But they will claim it, and of course the headlines get everyone's attention, and then all doctors say, oh, no, you don't want to take testosterone, it causes blood clots, where in reality, no, it was not statistically significant. It does not significantly raise your risk, but yet that's what's reported, and that's really a shame. But this is a quote from one of the authors, Dr. Ting. Dr. Ting says, I can't imagine why someone would even take the risk of taking testosterone. These are very potent substances. I would use it with great caution. It seems foolish to me to put myself at great risk for benefits which are not even that clear. Really? Dr. Tang, do you really read the literature? I don't think you really read the literature. Otherwise, to me, it's foolish that you would not consider taking testosterone for all the benefits that are definitely very clear. Let's look at some of those studies. This is from Mayo Clinic Proceedings, and this looked at the several articles that are commonly quoted, and I love when plaintiffs quote these articles. There's only 4 articles that were identified that suggested an increase in cardiovascular risk with testosterone prescriptions. 2 were retrospective analyses with serious methodological limitations and flaws. That has been reviewed by multiple authors, multiple studies, multiple societies. They've demanded the retraction of these 2 studies, and the PLOS 1 and JAMA will not retract them, which is unfortunate, because if they retract them, they say, well, then our peer-reviewed process was flawed. So they leave the articles in there, but unfortunately, there's significant limitations to those. There's one placebo-controlled trial with few major adverse cardiac events. Notice it didn't say MIs. It said cardiac events. Well, in this study, they increased cardiac events to not only MIs, but to other side effects like edema, palpitations, weight gain. They called those major cardiac events. When you factor out all those cardiac events that are soft and look at just MIs, there's actually a decrease in MIs in this study. And the amount that they had was like minuscule, but yet it's commonly quoted as a study that shows increased adverse cardiac events, not MIs, not death events, which was pretty much edema. We all know testosterone causes edema. Well, guess what? They saw that, and they called it a cardiac event. Shame on them. But one meta-analysis included questionable studies and events. You can design a meta-analysis to prove anything you want, and that's the problem with meta-analyses. Is there's meta-analyses that show benefit, there's meta-analyses that show harm, and of course this one meta-analysis used studies that were extremely flawed, and basically you can ignore the meta-analysis. In contrast, several dozen studies have shown a beneficial effect of normalizing testosterone. That's debatable what normal means. It's a catch-all term for you raise the level. It can be anywhere from low testosterone level, medium, or high. But I shouldn't say optimize, normalizing, whatever term that means, decreases cardiovascular risk of mortality. The mortality and incidence of coronary artery disease is inversely associated with serum testosterone concentrations, and every study shows this. The lower your level of testosterone, the greater your risk. The higher level of testosterone, the more benefit, the less the risk. Every study shows the same thing. Testosterone therapy, as far as improvement of symptoms and signs, reduced obesity, reduced fat mass. It reduces obesity and fat mass when you use enough of it. A couple of the most recent articles that looked at androgel used a very subtherapeutic dose, and they didn't see any improvement. Well, of course, because the levels went from 300 to 400. I wouldn't expect that. You got to optimize it. When you optimize on all those other studies, there is reduced obesity and fat mass. There is reduced waist circumference. What drug does that? Sorry, diabetes medicines, blood pressure medicines, statins do not reduce waist circumference in the fat mass. That's the issue. It's the visceral fat that's the cause of all these problems, and there's only one thing that we know that reduces it, and that's hormones. There's also improvement of glycemic control. Mortality was reduced. So that's great if you reduce all of these signs and symptoms, but does it result in an improved outcome? Yes. Mortality was reduced in 2 retrospective studies. Dr. Ting, what is it you don't understand about that? Well, they're taking an observation that is extremely weak and not statistically significant and saying, oh, it's harm, don't use testosterone, and they completely ignore the randomized controlled trials in men with coronary artery disease or heart failure reported improved heart function in those that received testosterone therapy with placebo. We'll look at the outcomes also of those studies where we gave testosterone in randomized controlled trials, which are certainly much more powerful than an observation which is entirely worthless. It's an interesting observation, doesn't prove anything, and as the article, it stated in the article, it does not prove causation. It does not prove that it does or it doesn't. It's just an observation. You got to study it in a randomized trial. The largest meta-analysis to date revealed no increase in cardiovascular risk in men that received testosterone. And, Dr. Ting, there is reduced cardiovascular risk among those with metabolic disease. There was decrease in morbidity and mortality. What is it that you don't like about that study? Why is it that you ignore those studies? Why do these guys ignore these studies? In summary, there's no convincing evidence of an increased cardiovascular risk with testosterone therapy. On the contrary, there appears to be a strong relationship between normalizing testosterone with testosterone administration and cardiovascular health that has yet not been widely appreciated. And that's the purpose of this webinar is to explain that and show all the data and all the articles and all the studies that everyone else seems to ignore. It is really a shame that it is ignored by the FDA. It's really a shame that it's ignored by AACE. But that's politics and economics at its finest, which is very unfortunate. This is an article that was submitted at the Endocrine Society's annual meeting about the risk of testosterone. To date, no studies have assessed whether an association exists between testosterone replacement and venous thromboembolic events. This is in 2015. There's multiple studies since then. So the purpose was to investigate whether there's an association between testosterone administration and DVTs in a retrospective cohort and nested case control analyses. What did this show? Results. 102,000 patients were treated with testosterone, 102,000 patients were untreated. Retrospective cohort analysis revealed a hazard ratio for idiopathic DVT that was 1.0 for all testosterone-treated patients. The nested case control analyses revealed similar non-significant findings. The hazard ratio was 1.0. Conclusion. The results from this study, 100,000 patients, big study, do not support an association between testosterone administration and an increased risk of DVTs. Another study. This is a nice one published in the journal Urology. It is mostly urologists that prescribe testosterone for men. It's interesting up here it says male sexual dysfunction. That's what the urologists are excellent at doing. Unfortunately, the rest of the world doesn't follow suit, and they want to limit prescribing testosterone. I've never seen or heard of a urologist limiting the therapy based on these new guidelines, which we'll get to. The objective of this study was to determine the prevalence of DVTs and all-cause mortality in men older than 65 treated with testosterone. We evaluated all-cause mortality, the prevalence of MI, TIA, CVA, DVT, pulmonary emboli. What did they find? There was increased all-cause mortality, sorry for the sarcasm, Dr. Ting, in men that were hypogonadal and did not receive testosterone. In comparison with those that did receive it, there was no difference in prevalence of MI, CVA, or PE between patients treated with testosterone and men not treated with testosterone. There's no evidence for it. We'll get to the study that shows, well, actually, there's evidence to show that it's protective. These are randomized controlled trials. They're not weak observations without control groups. Nice study, nice conclusion. Low serum testosterone is a marker of poor health and remains an independent risk factor for cardiovascular morbidity and mortality. Dr. Ting and others don't get that. They don't look at all the studies showing the lower your level, the greater your morbidity and mortality. What is it you don't understand about that? Well, it's an interesting observation. That's true. But you have to prove that raising the level is protective, and you have to prove that raising the level is not harmful. I like this first sentence. I like this paragraph. In contrast to AACE, that has to go by FDA guidelines, in contrast to the FDA, in contrast to other zealots, the goal of urologists should be our goal for everyone. The goal of testosterone supplementation is to ameliorate symptoms and to improve quality of life. What is it that you don't like about that? Well, they don't qualify for it. They don't qualify for improvement of symptoms. No, really? You call yourself a doctor and you're not treating the patient based on, you don't think they qualify because of a number, and you restrict it, and they could improve their symptoms and quality of life, but you restrict it and you don't want to give it to them because of a preconceived number that's designed to restrict? Yes. There's minimal adverse effects. Previously, elderly hypogonadal men reported marked improvement in libido, energy, sexual function after receiving testosterone, and you don't want to give that to them? You want to restrict that? Yes. They don't qualify for it. Really? It's interesting. Well, then I'm going to go to my urologist and get it. Urologists at least understand how to treat patients. Psychiatrists also know how to treat patients. Unfortunately, the rest of the world doesn't. Men receiving testosterone reported improvement in mood, energy, memory. You don't want to have the patient get better mood, energy, or memory? No, they don't qualify for it. Really? You think you're a good doctor? Yes. but you won't improve symptoms in patients. No, they don't qualify for it. Increases fat-free body mass. That's muscle. It burns fat. Is that healthy? Absolutely. For every lipid parameter, and you don't want to give it to the patient because they don't qualify for it based on their numbers. Shame on us. Despite several studies demonstrating the beneficial effect of testosterone for cardiovascular health, 2 epidemiologic studies in the past year, that was the Vegan and the Finkel study, have spawned debate surrounding the association between testosterone and thrombotic risk in elderly men. 2 extremely weak, flawed studies, denigrated by almost every medical society, everyone wants to hang their hat on, and they completely ignore all the studies showing benefit. In this study here that they looked at, 153 men received testosterone therapy. The use of testosterone in elderly men is reasonable given that these patients with symptoms, I will call it hypogonadism, it's an independent risk factor for cardiovascular disease and all-cause mortality. Then why would you let them suffer with it? Why would you let them continue with it? Well, because it's beyond the guidelines. The AACE and the FDA guidelines should be trashed if in their guidelines they restrict a therapy that protects men from cardiovascular disease and all-cause mortality. Shame on them. Furthermore, improvements in risk factors for cardiovascular disease, such as a decrease in body weight, a decrease in waist circumference, a decrease in hemoglobin A1C and all carbohydrate metabolites, total cholesterol decreases after initiating testosterone therapy. And it can contribute to the decrease in thrombotic events. Did you look at these studies, Dr. Ting? Evidently not. They're afraid of causing harm by giving testosterone, whereas in reality, it's withholding the testosterone is actually increasing the thrombotic events and the morbidity and the mortality. And they don't see it. They have no clue. Some of the weaknesses of the larger population studies that were flawed: lack of adequate control group, lack of availability of testosterone levels before and after their therapy. They didn't test levels, it was they got a prescription. And short-term follow-up. The study by Finkel was limited to 3 months after testosterone prescription was filled. You don't even know if they took it. You don't even know what the level was. There's no serum levels that were looked at to say, okay, well, this patient took it, the level went from 300 to 1,000. You don't have that. In the vegan study, only men who underwent a coronary angiogram were included. Great. Typically, men who undergo coronary angiograms do not represent the majority of patients presenting for testosterone therapy. Again, and that was the Kaplan-Meier evaluation as far as statistical analysis, which was really questionable for that study. In this smaller retrospective study cohort, testosterone supplementation does not appear to increase the risk of thrombotic events. Consistent with the majority of the studies in the literature, and that's randomized control trials, there was increased all-cause mortality in hypogonadal men not treated compared to men that were treated. Dr. Ting, look at this. Understand it. AACE, look at this and understand it. Consistent with the majority of the studies in the literature, FDA, look at this. Shame on you for trying to restrict something that helps decrease all-cause mortality. But more importantly, what was the outcome? There was no statistically significant difference in MI, CVA, DVT between patients who were treated with testosterone and those that were not. Study after study after study shows the same thing. We do not see any increased risk. The only increased risk is in these studies and these reports that are not really studies. It's really a shame that everyone wants to hang their hand on such a lousy study, a lousy observation, and unfortunately, I'll have to say, I think they were published by zealots. I mean, the attitude with which he speaks, why would you ever possibly want to take testosterone based on, these are potent substances. Well, yeah, it's potent to protect against you dying. Different study. This is from the American College of Chest Surgeons. Well, that's interesting. What do they know? This is a study that looked at whether testosterone increased DVT or PE. It is a retrospective study, unfortunately. Anyway, in this group, the final cohort consisted of 71,000 subjects. 10,000 did not receive testosterone, 60,000 did. Through all the different statistical analyses, there was no statistically significant difference in DVT incidence between the two groups. Another study showing no, there is no risk, there is no adverse effect. Conclusion, this study did not detect a significant association between testosterone replacement and risk of DVT. Another study showing the same thing. These are nicely done studies published in very peer-reviewed journals as opposed to somebody looking at a group and observing it and then writing their opinion of it. Really a shame. This is Mayo Clinic Proceedings, 2015. This is also a nice study looking at DVT. They examined the risk of DVT after giving testosterone. We conducted a case-controlled study, 30,000 men, who were enrolled in one of the nation's largest insurance programs for approximately 5 years. None of the specific routes of administration of testosterone, whether transdermal or intramuscular, were associated with any increased risk of DVT. Conclusion. This is, again, sort of a weak study because it was a prescription that they looked at. Having filled a prescription for testosterone therapy was not associated. This is similar to the Finkel study where they were given a prescription and then they looked at outcome. This one here is they give them a prescription, looked at outcome. Results are the opposite of that. These findings provide clinically relevant information about the benefit-risk assessment for men considering testosterone replacement, but yet everyone fears it. It's really a shame. In recent years, several case studies have raised concern about a link between testosterone and DVT. Yeah, it's interesting. They've raised concern. Lousy studies. In 2014, both the U.S. FDA as well as Health Canada, their FDA, required manufacturers to add a warning about the potential of DVT to the label of testosterone products on the basis of post-marketing surveillance. What is that? Is that a study? No. Is it a randomized controlled trial? No. Well, what was it? It was, well, people that took testosterone claimed to have had DVTs, PEs. Okay, but that's a neat observation, but that doesn't prove anything. But again, it's the FDA's responsibility at least to advise us of that, and that's why there's a black box label on it. I really think that what the FDA was trying to do, if you really have the insight, is to try to restrict the use of it. We're going to scare everyone not to using it. We're going to scare doctors into not prescribing it. We're going to scare patients into not taking it. We can't control the practice of medicine. We can't restrict the use of it, but we can scare the hell out of them by including warnings and changing the labeling on the testosterone in the guidelines to try to restrict the use of it. And that's exactly what they've done. Unfortunately, what they have done is scare people away from a therapy that's going to be extremely beneficial and protective. I don't think that's the job of the FDA, to scare people away from taking a therapy that is potentially life-saving. To scare people into thinking, oh, it causes harm, and not letting them take it is really what's causing more harm. However, there's evidence that testosterone therapy has protective endothelial actions. 2 large population-based studies reported that endogenous testosterone levels were not associated with DVT. Patients with high levels did not have an increase in DVT risk versus patients with low levels. To date, no comparative study examined an association between testosterone therapy and DVTs. Well, in the last 2 years we have, but in this study, again, 30,000 men filled a prescription. Same sort of apparent study. The association between testosterone and DVT did not appear to vary by the presence of underlying prothrombotic disease. This is an extremely important paragraph. In Glueck's study, he handpicked men that had factor V Leiden and took testosterone, and he showed in those individuals that they had an increased clot risk. Well, patients with DVT have an increased risk of blood clots. That's what happens to them. But he claimed that there was an increase, but he didn't have a control group. All he did was have an observation of factor V Leiden, he took testosterone, and got a blood clot. Well, maybe if you took testosterone and they did a control group, maybe the testosterone decreased the risk of blood clots. They didn't have a control group. All they had was an observation group. And because of that, everyone thinks it causes blood clots. But in this study here, even in those patients that had prior thrombophilias, factor V Leiden prothrombin mutation. They did not experience an increase in blood clots. Much different from Glueck's hand-picked patients in his observation. The FDA had previously warned about testosterone therapy associated with DVTs in men with a diagnosis of polycythemia. They assumed that since testosterone causes, quote, polycythemia, that there would be an increase in blood clots. Well, unfortunately, testosterone does not cause polycythemia. It causes physiologic erythrocytosis. And I keep looking for some big, large study, some large randomized controlled trial that shows that testosterone increases the risk of blood clots in those men that get erythrocytosis. So far, we don't see that in any good study. We also don't see blood clots in patients that live at altitude. There's 500 million people that have erythrocytosis that live above 7,500 feet. We do not see an increased risk of blood clots. We don't tell those people to run to the beach because everyone's getting blood clots. But yet, if you have erythrocytosis from testosterone, everyone interprets that it's polycythemia. They don't interpret that it's a physiologic erythrocytosis. Why don't they interpret that living at altitude and having erythrocytosis is polycythemia? Because it's not. It's erythrocytosis. Is that harmful? No. Yeah, but taking testosterone is not erythrocytosis. They claim it's polycythemia. An increase in red blood cells causes clots. Show me the study that it shows that. They can't. There is not one. But because of the potential for blood clots, because testosterone causes polycythemia, again, there are no blood clots, and it does not cause polycythemia. It causes erythrocytosis, which is physiologic and not harmful. Nevertheless, in June 2014, the FDA put out a warning of a potential risk of blood clots in men, even though they did not have polycythemia. That was a warning, and again, the warning that they got was extremely soft, but it's sort of their job to report it, but on the other hand, they scare people away. Given that testosterone is converted by aromatization into estradiol, I love this paragraph. Because testosterone is aromatized into estradiol, it may be prothrombotic by the same mechanism as estrogen-based therapies. You're kidding me, right? Did you really say that? Yeah. We know that giving estrogen increases DVTs. And you think that that's the same mechanism? Yeah. You think that testosterone increases clotting factors? Yeah. But where does it show that it does? It doesn't. But we think, well, maybe it's the same mechanism. No. There's no study with oral estradiol. There's no study with transdermal estradiol. And actually, there's a couple studies looking at levels of estradiol in both men and women. High levels in both men and women did not increase the risk of DVT in any of those studies. Those were observation studies. On the other hand, testosterone may reduce the risk of DVT by protective endothelial actions, which we ignore. Oh, you can't take it, it causes blood clots. No, it doesn't. Well, it protects against blood clots. Well, we ignore that. Why? Why do you ignore it? Our findings were generally consistent with two population-based studies that reported no association between endogenous testosterone and DVT. Why don't you like those studies? Why do you ignore those studies? They ignore the studies because they can. Why did you pick on weak, flawed studies to support your opinion? Because we can. I put those people in the context of zealots. They do not look at both. I look at both, but when you look at both and you see those studies that showed potential increase in risk of blood clots, so observation, extremely poor, weak, non-statistical analysis studies, or Glueck study, where they had factor V Leiden and they got blood clots. Well, you cannot state that. You have to take patients with factor V Leiden and divvy them up into two groups, those that got testosterone and those that did not. Randomize it, cross it over, follow it for a period of time. Then you can say whether testosterone increases the risk of blood clots in patients with factor V Leiden. You can't just look at a population and look at whether the records show that they had a DVT or not and claim that. This paper here looked at a couple of other studies. HomeRegard looked at high endogenous testosterone levels not associated with DVT. Swartberg did the same thing. They looked at endogenous total and free testosterone levels. They also looked at estradiol levels, and they were not associated with any increase in DVT. So having a high level does not increase it. But you still have to do a study where you give it and observe and see what happens. You have to see what the outcome is. You can't look at a baseline level to determine outcome of something that you give. That's what's important. Today, little published information is available about the potential risk. Several case studies, this is good, have reported DVT in patients with high rates of underlying familial and acquired thrombophilia, that was factor V Leiden, who received testosterone therapy. Interesting observation. However, because all the individuals in the DVT group were found to have undiagnosed thrombophilia or factor V Leiden, and because the studies did not include a control group or a non-testosterone group with comparable rates of underlying thrombophilia, it was not possible to determine the extent to which the blood clots were associated with testosterone versus the underlying thrombophilia. Terrible study, terrible conclusion, but yet it was published, not in a major peer-reviewed journal, but it was published. The FDA got a hold of it because it was submitted to them, and it is their job to report. Aha, see, it could cause blood clots. So now every patient that gets surgery has to stop the testosterone because of the potential increased risk of blood clots. And if the doctor does not stop it and there's a blood clot, which happens frequently, then the doctor's going to be blamed. So now, till the end of time, all patients that are having surgery have to stop their hormones or testosterone because of this report, this black box warning of an increase in blood clots, which is really a shame, but it's not supported by any study. In addition, a recent study by Friedman reported testosterone therapy interacted with thrombophilia to increase the risk of DVT. Again, poor design of the study. It did not allow for statistical analysis of the interaction between testosterone therapy and the underlying thrombophilia. Nice observation. Observation doesn't prove causation. You have to study it. You have to see what happens when you give it. Given the broad and clinical public health relevance of this issue, it's important for future investigators, particularly prospective comparative studies of testosterone users and non-users, they need to do that to rigorously examine this aspect. Well, I think this has already been done, but everyone tends to ignore those studies. They look at an observation and they want to prove causation. So what this study did, this is a large population-based comparative analysis of testosterone and DVT risk, and they didn't find any increased risk. Our studies suggest that middle-aged to older men receiving testosterone therapy do not have an increased risk of DVT. These findings may help to inform the benefit-risk assessment for men considering treatment, yet the doctors are afraid of it. They say, no, it causes blood clots. But yet all these studies, and large studies, very good studies, published in great journals, do not show any increased risk. We're so smart, but yet we don't understand our literature. Adverse events. A meta-analysis of randomized placebo-controlled trials. It wasn't an observation. They were randomized controlled trials. We performed a meta-analysis of randomized controlled trials to determine the risk of adverse events associated with testosterone replacement in men. They looked at a database from 1966 to 2004, many years. Testosterone-treated men were nearly 4 times as likely to have an increase in hematocrit, greater than 50%, in comparison with placebo-treated men. That is the incidence and risk. That's the main risk of taking testosterone, is the increase in hematocrit. People that don't understand it will call it polycythemia. People that will understand it will call it physiologic erythrocytosis, which is what it is. The frequency of cardiovascular events, sleep apnea or death, was not significantly different between the two groups. Even in patients that had an increase in hematocrit, which was the most frequent related adverse effect, did not have an increased risk. Testosterone-treated men were 3.6 times more likely to develop an increase in hematocrit that was over 50% than in placebo-treated men. But still, we didn't see any harm in this. This meta-analysis, which pulled data from 19 randomized controlled trials, revealed significant higher frequency of an increase in hematocrit. In some studies, over half the men had an increase in hematocrit in comparison with placebo-treated men. Hematocrit greater than 50% was the most frequent antigen-related adverse effect But unfortunately, we can't find any study that shows that that has an adverse effect on anything. Cardiovascular event rates did not differ significantly between testosterone-treated men and placebo-controlled men. We see that in every study. All I need to do is see the randomized control trial, of which there are many, that showed an increased risk of PE, DVT, MI, stroke, that are good randomized control trials, not an observation with weak data. Almost every study has an increase in hematocrit, but we don't see any adverse effects in these studies. Could it? Yes. Can it cause polycythemia? According to the FDA, it causes polycythemia. Yes, it does cause erythrocytosis. Is that harmful in any study? Not that we can find, but we know it causes polycythemia, which is harmful. No, it does not cause polycythemia, and yes, polycythemia is harmful. But testosterone does not cause polycythemia. There's a significant increased risk of blood clots, DVTs, PEs, heart attacks, and strokes in patients with polycythemia due to the increase in platelets and platelet adhesiveness. You do not see an increase in platelets with erythrocytosis. These results are consistent with studies that suggest either neutral or slight beneficial effect of testosterone on the risk of heart disease. Let's look at this. Okay, testosterone causes polycythemia. Okay, great. Does it cause any harm? Not that we see. Does it cause benefit? Yes. Really? So testosterone causing polycythemia can reduce the risk of heart disease? Yes. Really? But that's not what they say, I know. Testosterone does not cause the polycythemia that they so claim. Other studies. This is a nice study looking at outcomes. It's an outcome study. It's not an observation of what happens when you look at insurance files. In this study here, the cardiovascular risk was 23% in patients not treated with testosterone, 16% in patients treated with testosterone. Which group would you like to be in? Similar results were seen when the outcome was restricted to combined stroke and heart attack. The relative risk was 0.7, combined heart attack 0.6. Which group would you like to be in? The 0.6 group, that was the testosterone group. Dr. Ting, which group would you like to be in? The one that had much less cardiac events or the one that had the higher risk of cardiac events? If you pick the higher risk of cardiac events, that's an untreated group. Conclusions and relevance. Among men with androgen deficiency, dispensing testosterone prescriptions, again, this is sort of a weak, well, we prescribed it, was associated with a lower risk of cardiovascular outcome of 3.4 years. The authors performed an extensive literature search, that's nice, to examine the relative risk of cardiovascular disease. Serum testosterone concentrations were inversely associated with coronary artery disease and mortality. The higher your level, the more protective, the less heart attack. The lower your level, the more the heart disease, the greater the mortality. Which group would you like to be in? Compared with placebo, testosterone therapy was shown to improve cardiac function, glycemic control, reduce waist circumference, reduce visceral fat, reduce obesity. Which group would you like to be in? Based on the published data, testosterone therapy is not associated with cardiovascular risk. Conversely, the literature suggests that normalizing testosterone benefits cardiovascular health. Which group would you like to be in, Dr. King? Why would you suggest that patients fear it when all the studies show benefit and less heart disease and less MI? These are outcome studies. I don't understand why the zealots ignore this data. Take-home message. The FDA published additional information and changes in testosterone replacement guidance, and this is the criticism from our organizations. For 15 years, the FDA defined hypogonadism as symptoms. In that landmark study published in 1999 in JCEM, the explanation of hypogonadism was symptoms. They specifically stated there was no biological parameter, there was no number that defined a deficiency. It was based on symptomatology. So the FDA approved testosterone for use in men that had symptoms, and for 15 years we prescribed it based on symptoms. But then the FDA had to change it to try to restrict it. So they amended the definition of hypogonadism. Testosterone therapy is FDA approved for replacement therapy only in men that have low testosterone levels. That's 2 tests, 8 o'clock in the morning, less than 300. So if you have one test that's 290 and one test that's 301, no, they don't qualify. Really? Correct. And they have to have symptoms, and it has to be due to some disorder of the testicles, pituitary gland, or brain. I don't know how you define that. I don't know how you diagnose that. But that's the new definition of hypogonadism for which testosterone is FDA approved. Does that mean that you cannot prescribe testosterone? According to some zealots, yes. I've read some recent papers that say you must have 2 tests that are less than 300, and you must have some pathologic problem that causes your low testosterone. It cannot be from just aging. Really? No. It's got to be a pathology. Okay, great. Well, that's the new diagnosis, the new definition of hypogonadism. Can you still prescribe it? Yes. In webinar 4, we will look at this paper that's called, it's from the American Medical Association, from their journal called Ethics. We will look at off-label prescription. We will look at all those definitions of off-label prescribing. It is perfectly legal to do so. Yeah, but it's not. It's beyond the FDA indications. Yes, you're right, it is. Is it legal to do that? Absolutely. Can you do it? Yes. Is it indicated? Yes. As long as there's medical studies to show support for it and efficacy for it, then you can prescribe it off-label, which brings me to the next paragraph. The FDA has become aware that testosterone is being used. Really, they're becoming aware. Really, that must really upset them. They're becoming aware that testosterone is being used extensively. Yes, that's why we use it, to make men better. In attempts to relieve symptoms in men who have low testosterone for no apparent reason other than aging. It is not FDA approved for that use. I agree, it is not FDA approved for that use. Well, then you can't use it. No, where does it say you can't? Let's look at AACE guidelines. What do the AACE guidelines say? It says that you must have. It says you cannot use it. No, that's not what it says. It doesn't say you must have, and it doesn't say you cannot use it. Go to the guidelines. The guidelines state, we suggest. Really? That's all it says? It doesn't say you have to? No, it says we suggest. It doesn't say you have to. We recommend is what it says. It doesn't say you have to. But yet the FDA wants you to think that you have to and therefore that you cannot. There's a silver lining to this. If most doctors follow that dictum and are afraid to use it, then that leaves more patients for us to prescribe. Maybe that's not bad. While manufacturers and providers must take these warnings seriously, many men with significant low testosterone levels benefit greatly from testosterone. Well, why would you restrict it? Because of the new guidelines. Why do you take a guideline to restrict a man feeling and functioning better and having less cardiovascular disease? A Medline search was performed 1940 to 2014. Wow. Using all of these terms, only 4 articles were identified that suggested increased cardiovascular risk. Those are the Vegan and Finkel studies with serious methodologic limitations and flaws. This is another study. There were 5 deaths in the non-treatment group, 0 deaths in the treatment group. Which group would you like to be in? Not only that, but there's no difference in thrombotic events between the 2 groups. This study adds to the growing body of literature. What is it that they don't understand or like about all these studies? This study adds to the growing body of literature supporting the safety of testosterone in men and further highlights the potential all-cause mortality of low testosterone levels in this population. What is it that we don't see? Why don't we like this? It's really a shame that we ignore this. One more study. There's increased all-cause mortality in men not treated with testosterone compared to men treated with testosterone. What is it that you don't like about that statement? What about it that you don't understand? Well, these other studies, if you keep trying to hang your hat on these other weak studies. You have no concept or clue how to read or analyze studies. What a shame. I think they use it as ammo not to prescribe it. But it's okay that they don't prescribe it. I'm happy that they don't prescribe it. Then the patients come to me. There's no difference in prevalence of MI, CVA, or PE between patients treated with testosterone and men not treated. Another study showing the same thing. How many of these do you want to see? Well, we got more. The cardiovascular issues associated with testosterone replacement therapy have been clarified by recent studies, showing that the therapy associated with clear increases in serum testosterone levels to normal range is associated with reduced all-cause mortality, heart disease, stroke, bone loss, cancer, diabetes. What about this, Dr. Ting, do you not understand? Why don't you believe that? Studies reporting to show increased risk have been subject to flawed designs with inadequate baseline diagnosis and follow-up testing. Don't try to hang your hat on a flawed study. I will show in the literature, paper after paper, society after society recommendation that these are severely flawed design studies. There's a high level of evidence that hypogonadism is associated with increased all-cause mortality and reduced quality of life. And the reason that you don't want to improve quality of life, well, these are potent substances with no clear benefit, really. What is it about all these studies that you don't read and don't like? What a shame. There's a considerable body of credible evidence over several decades that testosterone replacement therapy, according to the expert guidelines, is safe and efficacious. There's emerging evidence that testosterone replacement therapy in such cases reduces all-cause mortality. Study after study after study supports that. Good study after study, not bad study. Recent studies suggesting that testosterone may increase cardiovascular risk are severely flawed. Another study showing the same thing. They do not exclude the possibility that the increased risk is really due to the hypogonadism and not the treatment. In contrast, the European Medicines Agency, 2014, concluded that there is no consistent evidence of increased cardiovascular risk with testosterone products. I like this definition that they came up with. It's completely different than the definition by the FDA. The definition that they came up with a biochemical syndrome, it's a syndrome, associated with advancing age, characterized by deficiency in serum androgen levels, with or without a decreased genomic sensitivity to androgens. This is the important point here. Well, your level's normal, you don't qualify. Yeah, but what about my symptoms? That's tough. But study after study shows that men can have insensitive receptors. Your level can be perfectly normal and you can still have symptoms of a deficiency based on the fact that you don't have receptor site sensitivity, receptor site attachment, and signal transduction inside the cell. That's what is responsible for benefit and symptoms, not serum levels. Study after study looks at serum levels do not predict symptoms, and they do not predict who's going to get better. How do you predict who gets better? You treat them and see if they improve. If they improve, then you continue it. It may result in significant alterations in the quality of life. Why do you want to restrict that? You want to restrict improvement of quality of life based on a number that's randomly picked that in no study is associated with who's going to get better or who's going to improve? Yes. Are you crazy? It adversely affects the function of multiple organ systems, the brain, the heart, the blood vessels, lipids, the pancreas. All of those symptoms are adversely affected by low testosterone levels and improve when you give it. Why would you want to restrict that? It makes no sense looking at the studies. European guidelines suggest that they have a certain low testosterone level to qualify. But if they have a level greater than 12 nanomoles per liter or a free testosterone greater than 25, it does not require treatment. That's the guideline for diagnosis of hypogonadism. Between these levels, a trial of therapy should be considered based on what? Symptoms. Really? You mean you really want to treat the patient? You want to improve their quality of life and their health? Yes. And you don't want to restrict it based on numbers? Yes. Then why do they come up with the numbers? Because they have to. Important symptoms: erectile dysfunction, loss of sexual desire. Well, you don't qualify for treatment. You mean I got to live like this? Yeah. For the rest of my life? Yeah. All because my level doesn't qualify? Yes. Really? What a shame. This important indication for testosterone therapy is often vitally important to the patient. Of course it is. That's why they seek treatment. That's why patients go to urologists, because they understand. It's considered to be of low importance by the physician not specializing in sexual dysfunction. Fortunately, psychiatrists and urologists specialize in sexual dysfunction. They do not limit treatment based on a number. They don't limit treatment. They give treatment, and that's vitally important to the patient. What is it that we don't understand about that? Shame on us. Shame on the FDA. Shame on AACE. Normalization of testosterone reduces the incidence of myocardial infarction and mortality in men. What is it that we do not understand that? In this large observational cohort with extended follow-up, normalization was associated with reduction in mortality, MI, and stroke. Which group would you like to be in, Dr. King? This is from the European Heart Journal. What is it that we do not understand about this? Why do you ignore it? Another study, Journal of Clinical Practice. What's known? Several longitudinal studies have shown that low levels of testosterone portend an increased all-cause mortality. 2 long-term retrospective studies show reduced all-cause mortality. What's new? In this retrospective study, it confirms the above. Low baseline testosterone increased all-cause mortality. Testosterone replacement therapy independently associated with reduced all-cause mortality. Which group would you like to be in? What is it that we do not understand about these studies? Why do we ignore it? It's amazing. Testosterone replacement is associated with reduced mortality in men with diabetes. Replacement therapy has been reported to be associated with adverse cardiovascular outcomes in 2 studies, but these studies, again, are severely criticized because of their flawed design. In contrast, this study by Biochemical found no association between testosterone and increased risk of MI. Interestingly, testosterone seems to have a protective effect in men at high risk of compromise of composite MI. In fact, the greater your risk, the more benefit in decreasing MI. Several recent studies have showed that in men with cardiovascular disease. There's a significant decrease in those individuals. It's protective. Which group would you like to be in? The placebo group? Not me. But yet everyone fears it. In the next webinar, we'll look at the most recent studies published in JAMA. And I've had several patients say, well, my doctor took me off the testosterone because it increases soft plaque. Really? Your doctor did that? Yeah, he's afraid because of the increase in soft plaque. What about the hard plaque? Well, that decreased. So he completely ignores the hard plaque, which is predictive, and the soft plaque, which is not predictive. He ignores that, yes. And the other study showed outcomes after 3.6 years, marked decreased risk MI, and he ignored those? Yes. Really? Yes. My suggestion is just switch doctors. Yes, I agree. Sorry for my sarcasm, but why do they do that? In this one study here, Anderson et al. Showed a significant reduction in mortality and major adverse cardiac events related to achieving high levels of testosterone, with no suggestion of an increased event in men treated to levels in the upper reference range or above. Really? I see people have fits when the testosterone level is above the upper end of the range of normal. Yet the literature says there's even benefits to that, and there's no harm to it, but everyone has fits. For those of you that have taken the courses, you understand now why I use the levels that I use. You understand why the high level works, the reduction of visceral fat. Nobody wants to reduce visceral fat. The cardiologists completely ignore the reduction in visceral fat. They're treating the outcome of the visceral fat, but they're not reducing the visceral fat. But yet in these studies, The higher the level, the more improvement of reduction of visceral fat. And as you know in the studies, it has to do with the level of estradiol that you achieve. Sharma et al. Retrospectively examined 83,000 men. The all-cause mortality, the hazard ratio, was 0.4 for mortality. The risk of MI was 0.7. The risk of stroke was 0.6. It was significantly lower in men given testosterone. What is it about this study that we don't like and don't understand? Well, there's two other studies. Those are severely flawed studies. Why do you keep going back to those severely flawed studies that are meaningless, and you ignore these good studies? These two studies highlight the importance of achieving therapeutic levels. What is it that you don't understand about this? They just don't. They don't understand it. But this is a nice study. It's a 5-year study of testosterone undecanoate injections. Normalization of testosterone levels in men with a metabolic syndrome, improved obesity, glycemic control, blood pressure. It lowers blood pressure, both systolic and diastolic. It improves all lipid parameters. This is the first long-term non-sponsored, meaning non-drug company sponsored study. Over a 60-month period, no serious adverse events were reported over time. In conclusion, this study demonstrates that testosterone therapy has favorable effect on body composition, body fat, metabolic parameters, carbohydrate markers, lipids after 5 years. The present study also provides evidence of a remarkable reduction in blood pressure and heart rate. I can't find any harm in these studies. Concerns regarding cardiovascular and prostate cancer risk are not supported by the current evidence. On balance, testosterone therapy can be considered a safe and effective treatment for testosterone deficiency. This is the most recent, one of the most recent studies by Morgenthaler in a urology journal. Introduction, I'll review the article. Clinical interest in testosterone deficiency, also known as hypogonadism, has increased along with a greater appreciation of the beneficial effects of testosterone that Dr. King does not understand on sexual symptoms, general health, and wellness. Evidence has accumulated over the past decade has shown that testosterone deficiency increases metabolic syndrome, obesity, diabetes, cardiovascular disease, depression, mood changes, an increase in Alzheimer's disease, frailty, and all-cause mortality. Where would you like your levels to be? Look at that paragraph. Where would you like your levels to be? Well, my levels are low, but my doctor says I don't qualify. Perfect. You want to get these things? Your doctor wants you to get those things. Well, I guess so. A substantial body of evidence is showing that testosterone therapy reduces these problems. Why doesn't your doctor want to do that? Well, he says I don't qualify. You don't qualify for Alzheimer's disease protection? You don't qualify for reduction of obesity and fat mass? You don't want to reduce your waist circumference? You don't want to improve muscle mass? You don't want to improve insulin sensitivity? What a shame. Traditionally, testosterone deficiency is referred to as hypogonadism. However, in our opinion, the use of this terminology is problematic because testosterone deficiency can occur in men at any age. It's not purely related to number. It's related to symptoms. A more accurate term for hypogonadism in the absence of a known underlying cause is idiopathic hypogonadism. Yes, but it's not FDA approved for that. It doesn't mean you can't use it. Oh, but it says you must. No, it doesn't say you must. It says we suggest based on new FDA guidelines that are designed to restrict. The term testosterone deficiency is now preferred by many experts over hypogonadism because it's really the symptomatology and not the number, whereas hypogonadism is defined by a number. Testosterone deficiency is defined as symptom. The diagnosis of testosterone deficiency usually requires the presence of characteristic symptoms and signs with confirmatory blood test of low testosterone. Unfortunately, based on these guidelines, men with symptoms but clearly entirely normal testosterone levels are not considered to be candidates for treatment. It's designed to restrict them. Why? Fortunately, this article debunks that. Most common sexual side effects: low libido, erectile dysfunction, difficulty achieving orgasm. So you don't want to give me testosterone to improve that? No. You mean I got to live like this? Yes. Really? Yes. That's what we tell them. Sexual symptoms: reduced sexual desire. Fear of spontaneous erections are the most common reasons that men seek help. Non-sexual symptoms also include loss of energy, fatigue, poor concentration, depressed mood. Here, take an antidepressant. It doesn't help my energy. In fact, it makes me more depressed because it gives me erectile dysfunction. Why can't you give me testosterone? You don't qualify. Nonsense. Reference values can differ widely from one laboratory to another, even using the same equipment. A survey of 25 laboratories in the U.S. revealed 17 different total testosterone ranges with the same machine. The ranges were from 130 to 450, a difference of 350%. Even if a set of reference values accurately reflected an appropriate population, this approach arbitrarily categorizes only the lowest 2.5% of values as low. Regardless of the actual prevalence of the condition or the symptoms, you don't qualify. Really? Because of a randomly picked number? Yes. What a shame. What an absolute shame. For this reason, we encourage, thank you, Dr. Morgenthaler, we encourage clinicians to use clinically based thresholds, symptoms, rather than laboratory reference ranges to help with the decision making in regard to testosterone values and treatment. A man with classic symptoms of testosterone deficiency but with testosterone levels in the normal range still would benefit from testosterone therapy. Such patients are quite common in the clinic. We all see this. And yet we fear this FDA guideline. Don't fear it. You can prescribe outside of the guideline. Where does it say that? In the Journal of Ethics from the AMA. Determining the correct course of treatment can be hindered by the fact that in general, testosterone values in the blood might not accurately reflect concentrations in target tissues. And the activity of testosterone can vary from one individual to another. But yet we want to restrict it based on a number. Isn't that a shame? Get rid of the numbers. The original guidelines were to treat symptoms. Morgenthaler and the urologist, they treat symptoms. Thus, with men with relatively insensitive androgen receptors, might lead larger doses of testosterone and a higher final testosterone level than younger men with androgen receptors of normal sensitivity, in order to achieve the full spectrum of benefits conferred by testosterone therapy. But everyone's afraid of that number. Oh, that number's too high. You're trying to kill the patient. Where does it say that you're going to kill him? Where does it say it's harmful? Well, it could be. It also means it could not be. There could be life on Mars. It also means there could not be life on Mars. Until you can show me proof of it, there is no life. Until you can show me proof that it's harmful, it's not harmful. Yet, in all the studies, a higher testosterone level helps men feel and function better. Thus, we disagree with the recommendation by some experts, I don't call them experts, to deny treatment to men with testosterone values above a firm threshold. Our first concern is alleviating symptoms in our patients. Isn't that the oath that we took? Well, we should do no harm. By not giving it to them is causing harm. Symptom-wise, sign-wise, outcome-wise. The various proposed thresholds are arbitrarily established, and they're designed to restrict. And they're unable to reliably diagnose and distinguish between those that will benefit from testosterone therapy and those that will not. Treat the patient, treat the symptoms, just like we were taught in school, and use the number as a guide. If the level's low, great. If the level's not low, don't restrict it. Yeah, but the guidelines say the guidelines are meant to restrict, not treat. One retrospective study demonstrated that clinical benefits were seen in a substantial number of symptomatic men with normal testosterone concentrations. Really? Imagine that. But why would a man with normal numbers get treated? Because he has symptoms. Why would his symptoms improve if his levels are normal? Because his levels are not optimal. Yeah, but the normal, you're stuck on a normal. You assume that a normal level means they don't need it and that they don't have symptoms. The number is meaningless as far as symptomatology is concerned. We'll look at those studies in Webinar 4. If the clinical presentation is strongly suggestive, we favor a 3 to 6 month trial of testosterone therapy with close monitoring of the response. This approach is also supported by professional society guidelines or recommendations, such as the European Association of Urology and the International Society for the Study of Aging. I do not know of any guideline, urologic guideline, that restricts therapy here in the U.S. It's only the AACE guideline that restricts it based on their instructions from the FDA. What a shame. Okay, I hope that was fun. I hope that it was a good introduction and a rebuttal to the vociferous reports from zealots. There was an article recently in PLOS One, and this article said that none of the studies showed any benefit of testosterone. None of the studies supported improvement sexual function, improvement of cardiovascular disease, improvement of weight, improvement of lipids. None of the studies showed anything, and the conclusion from these authors from PLOS One was, it makes no sense to use it. With the risk and harms of it, and there's no benefit, it makes no sense to use testosterone. Really? What do you think their agenda was? What do you think? Those are the people I call zealots. They completely ignore the information and the data that I've just shown you. So I hope that you look at the real data from the real studies and the randomized controlled trials that show benefit, as opposed to the opinion from Dr. Ting and others, as well as the PLOS One authors that have an agenda. There is an agenda out there. There is a pushback agenda out there. There's an agenda from the FDA against the use of it. It is a battle, it is a war, but we will use our science and our literature to support why we do what we do, and we will support why we do what we do based on the scientific literature is completely appropriate in contrast to the opinions of others, and their opinions based on their flawed studies hold no weight. Anyway, I hope that was fun. Okay.
For just a moment.
Questions?
Any of
Go
you
ahead.
that joined us, please note in the lower right-hand corner of your screen, you should see a question and answer box where you can enter your questions to Neal. I'll turn it right back over to you, Neal.
Thank you, Mary. Dr. Robert Morgan asked, Texas. I don't understand the question, sorry. Jason Marchetti asked, do you have a list of citations that go with your slides? You can contact Mary or Dana at WorldLink, and they will be able to provide you with a list of those articles. If you're a member of EBSCO through WorldLink, you will have access to each and every one of the articles. Robert asked, hi Bob, do you have these studies in a file that you can email? I cannot email you these studies. I can use them for personal use. I can use them to lecture from, but because of copyright laws, I cannot email them. WorldLink can also not email all of these articles to you. It's against copyright laws, and we infringe when we do that. However, if you're a member of EBSCO, then you can get those articles from EBSCO. It is a service that WorldLink Medical provides, and it's a subscription service that Dana has organized that you can get all of the articles from the courses and you can get all the articles from the webinars through EBSCO. It's not that we're trying to sell to EBSCO, it's that we cannot legally give you all those articles. Everyone wants all these articles. I cannot give you those articles, I'm sorry. Yes, Dana can give you the references if you want to look them up, but if you want all the articles in their entirety, full entire articles along with their references, then you have to go to EBSCO in order to be able to get those. The FDA, Jason says, the FDA now also states that corticosteroids are not approved for epidural injection, yet we do 1 million of these a year. Just because they say they're not approved, there's 1 or 2 studies to show that corticosteroid injections, epidural injections, do not work. I've had a couple epidural injections and they did nothing. I've had a couple epidural injections that got me from being flat on my back to outrunning the next day. It was like black magic. It just depends on what's wrong. If there's a really bad structural problem, no, it won't work. If there's a really bad inflammatory problem with a swollen disc, it works great. So how do you figure out who it works on? Well, you have to give it in order to see who improves. But yeah, sure, the FDA says there's studies to show that it doesn't work. Well, there's good studies to show that it does work. I understand what you're saying. Terry asked, any experience with botanical medicines? I have no experience with botanical medicines. And if they will achieve any degree of improvement with low testosterone symptoms, I have no idea. I'm sure that they probably do not raise levels. The only really good way to raise a level is with testosterone. You cannot do it with DHEA. Even very high doses of DHEA, even though it's a precursor to testosterone, does not raise testosterone in men. So even by giving the precursor, it doesn't raise testosterone. The only way to raise it is with Clomid, HCG, or by giving testosterone. I've been prescribing ashwagandha, daidzein, dan quai, all of the typical herbs that are used for treating adrenal fatigue or adrenal exhaustion with some promising effects. And there's some evidence that KSM-66 ashwagandha is helpful. I have no experience with using that type or just ashwagandha, but it may work. I don't know. But as far as raising testosterone levels, I don't think so. Symptomatic improvement, it very well could be. I don't know. But if I'm trying to decrease visceral fat, even getting a testosterone level to 500 or 600, 700 doesn't work. Your levels are going to have to be 15 to 1800 at least, which is high, but you have to get those levels that high in order to get your free testosterone level up. Then you will see a drop in the visceral fat. Then you will see an improvement in metabolism, and when you see the drop in visceral fat, that's when you will see the decrease in inflammatory cytokines. That's when you will see improvement in all the lipid parameters. But until you get the levels to that point, you're not going to be successful with the treatment, unfortunately. DH asked, same benefits in women? Absolutely. Same risk? No. I don't know how to answer this without being sarcastically humorous. Same risk? Well, what's the risk? Well, the risk is in testicular atrophy and decrease in sperm count. So yes, there's some women that have testicles still. Yes, they would still have the same risk. But the side effects in women are usually related to hirsutism and acne. Reduce the dose. Use spironolactone. Same benefits as in women? Absolutely. DH asks, so you treat based only on symptoms, no labs, or is there a lab that you trust best? There's no lab that I trust best. All the labs are okay, but I use the lab as a guide. I never restrict based on a lab report. The way I use a lab report is I get a baseline level, then I treat, and I show the patient, your level was originally 400. Now your level's 1,000 to 1,200. Look how your level has improved. Your free testosterone was originally 5. Now your free testosterone is between 30 to 40. Perfect. That's where I want it to be. That's how I use the labs. I use the lab to show improvement to the patient. On the other hand, if the patient says, well, I'm somewhat better but still not, all right, well, then I'll increase the dose. I wish I had $1 for every time I've increased the dose and the patient says, boy, what a difference that made. Yet I would have restricted increasing it based on that number. I don't restrict based on the number. I restrict based on they have an active prostate cancer. I don't restrict by any other mechanism, by any other means. There's no reason to. Well, my doctor says, okay, well, then you do what your doctor says. I can't help you. If you're going to go by what your doctor says, I can't help you. Why did you come to me to be treated? Well, because my doctor doesn't know what he's doing. Okay, then why did you factor your doctor into it? Well, he wanted to test my levels to see what they are, and he says my levels are too high. Okay, reduce your dose. Yeah, but now I don't feel as well. I know. Well, what do? I don't know. If you're going to factor your doctor into this, I cannot help you. John says, the best lecture I've ever heard you give. Really? Well, thank you. Just excellent. Well, thanks, John. In case you don't know, Right now, it's about 4 to 5 o'clock in the morning for me because I just got in from China last night. So I'm still on China time. So I'm giving this lecture in the middle of the night. And if it was good, well, maybe I should start giving my lecture by being up all night and being sleepy in the daytime. Anyway, thanks, John. I appreciate it. Dr. Morgan says, at the beginning you said you were visiting your favorite place in the world. Oh, I assume it was Texas. No, it's not Texas is not my favorite place in the world. But when you die, you either go to heaven or hell. And if you die and go to heaven, then you're in Texas. Did you like that? No, my favorite place in the world is actually Yosemite. My second favorite place in the world is actually Glacier Park. When I die, I'll get sprinkled over a waterfall in Yosemite. Ron says, thanks, Neal. Great review. Thank you. What do you include in your consent form for cardiovascular disease DVT? In my consent form, I include that I tell the patient, the FDA has a black box warning. However, there's no good randomized controlled trials or good literature to support that. But that's what the FDA says in the black box warning. So I'm advising you of what the black box warning says, but I completely disagree with the black box warning. But I have warned you what it says. And I document that in my note, and I document that in the form that I give to the patient. Slightly off topic. I have 3 guys on testosterone for 12 months, 2 on daily cream, 1 on enanthanate with chronic facial flushing. Your best advice, don't give them testosterone. What does testosterone do? Yes, it causes vasodilatation. What's the mechanism? I'm not quite sure what the mechanism is, but it's described. You will get facial and chest flushing, just like you do with niacin. So it is a vasodilator response. The only treatment I know that helps it is 1, reduce the dose. 2, you can use baby aspirin, although I'm sort of against aspirin, but you can try baby aspirin and see if it works. It does work for the flush of niacin. I've had 2 patients that took the baby aspirin and said that it worked for testosterone. I've had a couple patients that took the baby aspirin and said it did not work for the flush of testosterone. So try it and see. Otherwise, I don't have any suggestions. But try it and let me know. Jason says, PubMed IDs are fine for citations. Yes. Dr. Gershon says, hi, Steve. I just got back last night. How long does it take for you to see changes in a patient's symptoms once you start testosterone therapy? It varies. It depends on what symptom it is. It varies on how much you give. It varies on what their level is, and it varies on the patient themselves. I typically tell patients 1 to 3 months. Some studies say that it takes 6 months to improve sexual function libido. That's a long time. Most people are able to see that change in about 3 months. So I tell patients 1 to 3 months, you'll start to see a change, and by the end of the year, you should see significant change. When do I see a change in receptor site sensitivity? There's no change in receptor site sensitivity. It's a change in stimulating more receptor sites. I can't change the sensitivity, but I can change the stimulation of that cell by stimulating more receptor sites, which results in more signal transduction inside the cell and improvement of symptomatology. So you have to get your serum levels up, then you got to saturate the receptor site, then you have to go through the signal transduction inside the cell that goes to the mRNA and produces the proteins and affects the change. That takes 1 to 3 months. Second question, I recently started a patient on 200 milligrams per gram, 1/2 gram BID of testosterone, and within 4 weeks, he gained 10 pounds without evidence of edema. It's still fluid retention. His numbers are perfect and he's feeling great. What would I do with respect to his weight? Again, the weight is fluid. You can't gain 10 pounds of fat in a month. It's very difficult to gain 10 pounds of muscle in a month. And if you worked out that hard to gain that much muscle, you'd be losing a lot of fat. So rapid weight change is fluid retention. Slow weight change can be fat or muscle. When you look at all the studies, and the studies looked at regular men that were not exercising, they lost considerable weight from fat loss, but they didn't lose muscle. In those individuals that will exercise and do weight training, you will see some improvement in weight, meaning increase in weight due to muscle. You'll also see decrease in weight due to fat, so it sort of balances out. But over a period of time, those people that continue to exercise will see an increase in weight that's muscle weight. Those that don't exercise or do aerobic exercise will see a decrease in weight secondary to fat loss. The initial weight gain is water. As I taught in the courses, testosterone does increase edema. You said there's no sign of edema. Well, it's probably just generalized fluid retention. Testosterone affects the distal renal tubule sodium-potassium exchange. And what happens is you'll excrete potassium, you'll retain sodium, and when you retain sodium back into the system, you'll draw water with it. When you draw water with it, there's your water weight. So what I would recommend is that you use Maxide for a month or two. It's usually transitory. You see this in the first month or two or three, and then it resolves and goes away. So for the first month or two or three that you see it, it's a problem, it's an issue. If they want to treat it, if it bothers them, then use a diuretic or stay off the scale. If it's not edema and he's not noticing anything, then what's he doing on the scale? Well, to me, it sounds like if he's on the scale, he wants to lose weight. If he wants to lose weight, he has some evidence of fat gain. I really believe that it's fluid retention. So use a diuretic. I think that water weight will go away in a month or two. Then you can stop it, and I think that you'll be at baseline. Next question. I should have said same no risk. I mean about cardiovascular disease, cancer, DVT. Yes, exactly. There is the same no risk. There's probably several hundred studies of testosterone use in women. In the Part 2 syllabus, I list that summary article that looks at all the different studies on testosterone, the risk, side effects, benefits. The risk were none except for an increase in acne hirsutism, which was minimal. Benefits, weight loss, fat loss, improvement of sexual function, better strength, endurance, loss of decrease in fatigue, improvement of energy, all of those beneficial things. In no study in women do we see an increased risk of cardiovascular disease, cancer, or DVT. In fact, we see a decrease in breast cancer. That's Part 2. Cardiovascular disease, that's also Part 2, where we see 1 or 2 studies in women with testosterone showing a decreased risk or incidence of cardiovascular disease. So it's beneficial for both. Dr. Wilson King, how are you, sweetheart? Says, I have not heard you in a long time. No, I haven't seen you in a long time either. My best to you. It's about time for me to return. Yeah, why don't you come to Part 5? Come to Part 4 refresher, or 3. Great lecture. I so miss your sarcasm. Well, thank you very, very much. You know, it's sort of funny that a long time ago, there was a one or two nurse practitioners that attended the course did not understand my sarcasm and humor. Most doctors don't. In fact, initially they say, you know, we really hate you at first. And then it sort of grows on you, and then as time goes on, in times that I've been sick and not felt well, I've not been as sarcastic, and people will know when I'm sick and not feeling well because they say I'm not as sarcastic or humorous as I normally am. So if I am sarcastic, that usually means that I'm feeling fairly good. Anyway, hope to see you soon. James says, I have a 52-year-old male on 80 milligrams testosterone cypionate IM. I assume that's per week. For 5 years with high lipids at 250. Coronary scan is clear. Good. The coronary scan will look at calcium scores. Calcium scores are what are predictive. Not plaque, not soft plaque, calcium scores. The higher the calcium score, the worse you are. And some of these studies look at reducing calcium scores with testosterone. That's what's important. It also looks at reducing hard plaque, which is also important. Total testosterone is at 700 with good free testosterone. Can't figure out the high lipids. No kidding, really. It's pretty obvious to me. I don't know why you would have him on 80 milligrams per week. I would do 200 milligrams per week, and that's just for starters. When you get the total testosterone up around 15 to 1800, then you will see a flip in your lipids. Then you will see an increase in the estradiol. When you see that, then you'll see the lipids flip, then you'll see the HDL go up, then you'll see the LDL come down. It's not until you get to a certain level that you will see that. A total testosterone of 700, sorry, worthless. I would not expect any change, and you see that in that patient. Hi, Dove. Thanks for the thanks. Yeah, I hope it's good evidence-based medicine. I mean, what else do we have to hang our hat on other than our science and our literature? And we have to use that science and literature to rebut criticism against what we do. And I use it on a daily basis to rebut, because the doctors will not understand. The doctors don't want to understand. It's a lot easier to denigrate it, reject it, because negativism breeds sensationalism. Whereas all the positive studies you never see. You never hear those. You never see on the front page of Medscape, another testosterone study shows benefit. No, all you see is another study shows an increase in blood clots. Another study shows increase in harm. Another study shows increase in plaque. You know, it's like, you know, give me a break. Negativism breeds sensationalism. I use our medical literature to show, yeah, well, what you said and what you stated is completely not supported by all the good medical literature. And that's why we use what we use. Anyway, that's the last question. Thank you very much. Look forward to giving webinar number 4 in a couple weeks. Thank you, everyone, and have a great day.
Thank you, Dr. Rouzier. I hope our listeners enjoyed it as much as I did. Our next webinar will feature part 4 of this topic and is scheduled for April 11th. Archived versions of all webinars can be found on the website under Resources and Webinar Library. Part 3 of bioidentical hormone replacement is around the corner, and there's always new information coming out. Think about attending a refresher training if you haven't been in a while. Thank you again, Dr. Rouzier, and everyone who joined us today. Have a wonderful rest of your day.